Thank you to TAN CSI team. Thank you to Veeramani sir and Dr. Madhavan sir and many seniors for having us as part of TAN CSI. We are privileged. To my right is my esteemed colleague, Dr. Anantharaman, international cardiologist, and we have Dr. Sivaraman, who is a cardiac surgeon here, and it is indeed Dr. Sivaraman's patient from MMC that we are trying to operate here along with the heart team support from Dr. Sivaraman. Today's patient, I'll just go through the history very quickly. I'm told we have only 15-20 minutes, so I will try and show as much as possible. So we had two cases lined up, so we're just going to go for a paravalvular leak, a structural case. Slides, please. Next slide. Just go back without. Go to the other one. Next presentation. Not this one. So we had two, one was a TAVR and the other was a paravalvular. I'm told we have 15 minutes, so we'll just go for whatever we can show now quickly. Next slide. So our patient is Mr. SB. He's a 26-year-old male. His symptoms are essentially shortness of breath on exertion. Next slide. His past medical history largely surgical. As you can see, he had a SAVR with a 21 millimeter St. Jude mechanical prosthesis for fungal endocarditis in November 2018. He unfortunately developed a paravalvular leak after the first operation, and he had a surgical paravalvular leak repair in February 2019. Subsequently, that cost him only a little benefit, and quickly he developed more paravalvular leak, and this led him to have shortness of breath. Next. This is his clinical examination. His diastolic was 40 with a loud EDM and an ESM also. There were no signs of cardiac decompensation. We'll go straight to the echo. Let's go to the first echo, please. Very first, ma. Very first. Very first. First. Okay. Shows the LV. Can we show the echo screen, please? I hope you can see the echo screen, sir. There.
Yeah, we can see Gopal. Gopal, I am Dr. Justin. Here with me is Professor Hari Krishnan, Professor of Cardiology from Chitra, and Professor Ravichandran Edwin, HOD Cardiology from Tirunelveli Medical College. We can see you clearly and the echoes clearly.
So the echo, I hope you would agree, shows LV dilatation. Next one, please. Please stop me, I am rushing because we have little time. There was MR. We graded it as moderate MR, which was more functional. There was no mitral valve abnormality. Next. There was severe aortic regurgitation, and in this view you can see it appears to be a paravalvular jet from the aortomitral continuity area. Next one. Next one. Next one. And on the short axis view, we thought it was all around the 9 o'clock position on TOE. Next. 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 That's a good view. So here you can appreciate the large crescentric paravalvular jet. Again, one can't be very sure from what we could see whether we are cutting exactly at the hole or whether we are cutting at where the aliasing is, because we may tend to overestimate the actual hole. Next. We will just show you more views. Next. Next. So here you can see another view showing the paravalvular leak. Next. 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 And here I think one can appreciate that on the explain, it's a continuous jet from that non-coronary sinus down across the AM aortomitral curtain. Down. Next. 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 Okay.
Guiding pull back பண்றேன்டா.
The echoes. So we then proceeded to vascular access with ultrasound guidance, which is the norm here. So show us that, please. So you can see here peripheral ultrasound, clear common femoral bifurcation. Next. 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 So there you can see access gained from the left side and the right side. So we have some arterial accesses. We got 2 accesses on the right side in preparation that we may require 2 devices. Dr. Anantharaman will go through the angio steps while I just work along here.
So what was your approach? Was it through the antegrade approach or the retrograde approach? What was your plan from the echo?
We planned for a retrograde approach, sir, because with aortic regurgitation, usually we've not had many major problems going retrograde. For mitral, because it is in the direction of flow, I would usually prefer a transapical puncture because you just cross in a straight shot. But in AR, usually we would cross retrograde. What do you think, sir?
Retrograde only. So what device were you planning?
So we have 3 devices at our disposal. We have AVP3s, but the selection is very little. We want to use an AVP3 because AVP3 is a dedicated paravalvular leak device which has a rectangular profile, and the LV aspect of the disc is as minimal, that has less chance of interference with the aortic bioprosthetic metallic leaflet. So we have AVP3, we also have ADO and AVP2s. The patient's blood pressure, which we will show you a screen, invasive was diastolic of 27, so we had to get on very quickly after intubation. It did drop significantly. Can we show the pressures please on the screen?
So we started with the retrograde approach, sir, and we crossed with multi-purpose. Used a multi-purpose, a straight J wire, straight wire, thermo wire. Show that steps. Once we crossed, then we took the guide catheter in.
Gopalamurugan.
And exchange it to.
Sir, you're there. I can hear your voice. Great, super.
Yeah, thank you. Actually,
suddenly you've added confidence to my procedure.
Okay. In the short axis view, we were clearly seeing the leak that you are showing in the 9 o'clock, but there appears to be another one between 12 and 1 o'clock bang posterior, because on all your long axial views you are seeing something posterior to the, so it looks like there is one in 9 o'clock and one in between 12 and 1. And it will be interesting to know what was the surgical finding when in February 2019 or whatever be the second surgery that was done. Where did the surgeon detect the paravalvular leak and how did he suture it?
So we don't have a mic for Professor Sivaraman here. He's a surgeon who operated. What we understand is when he operated, there was a large leak in the non-coronary sinus only. He could only see one leak. There was no other leak anywhere else, and he had closed it surgically at that stage. Am I correct, sir? He concurs. So here, other than that one view that you saw, one of the concerns we had was whether we were cutting it at an angle and we were catching a serpiginous jet. One end on the top, one on the bottom, it just appears as 2, but actually it's 1. That was the other concern, because that was only view, sir. I think your point is well taken. In any other views, we could not see the other jet. So we decided to just go retrograde and try and get access and map around the annulus in an on-fast view. So we'll show you what we did so far. Do you want to go through?
Yes, Dr. Anantharaman here. So show me the pictures. So basically we went retrograde, we took a multi-purpose and a straight wire. First we started with the iotogram. Show the iotogram. It shows a torrential AR, but it's difficult to identify the track, both RA LA views. Show the next. And you can see the valve is functioning well, absolutely fine, no restriction, and it's functioning well. Show the next. Next. So that's a multi-purpose, and show the next. A straight wire. It went straight in. There was no difficulty at all getting it through. Show the next. So once we got that, we used a sizing balloon about 4 millimeter. Show the next. 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 Next.
Balloon size.
This is a 4 by 20. Show the next. This is coronary balloon because even the catheter was struggling to go through. 4 by 20, sir. 4 by 20. With the balloon inflation, the pressure came up. The diastolic came from 27 to 35. So there was some sort of improvement. But as you were absolutely pointing out earlier on, there were 2 jets. So the echo was still showing more than moderate to severe AR.
If you do an angio while you are inflating the sizing balloon, if you can do an angio while you are doing the sizing balloon, you can see whether there is another leak.
No, you are absolutely right. But the echo was already showing as moderate to severe AR. Severe AR was there, so we were convinced that there is another track with a larger jet.
Do you have a concern that the sizing balloon will increase the size of the defect? Shiva, do you do sizing with the balloon?
Yes.
Yeah, actually it is quite challenging in a small aortic annulus to exactly get a size, and this is probably one indication for using a sizing balloon. But I prefer a Tyshak 2 balloon, which is an extremely compliant, a soft balloon, and just inflated to 1 to 2 atmospheres. Whereas these coronary balloons are notorious to go on to very high pressures, and they can distort the annulus as well. But I think aortic paravalvular leak is one area where sizing balloon helps, because it's very challenging to get the size.
No, you are. What you said is absolutely right. We also use Tyshak routinely, but here we were a little bit concerned about the size because the guide catheter was struggling to go through, so we were concerned about dilating it more. So we went cautious and took a 4 by 20 coronary balloon.
So just show the map.
Show the next. So then we kind of fished around for the next defect. As you can see, we got a AL1 and a straight wire, so we were sweeping from left to right and see whether there's another defect. Show the next. So we got a parallel wire and a second catheter as well.
So what we did was we tried to march around the metallic annulus on an on-fast view to make sure if there was any other holes. And in spite of multiple attempts, we could not get anywhere other than getting a wire pretty much very close to where our sheath is, which you can see now. So we were reasonably convinced there that we probably are not missing a large hole. We may miss something. On echo, we could still see color with this catheter on and with the balloon on. So clearly the hole was bigger than the catheter. There was no reason to do an iotogram because we never found iotogram to tell us where the hole is. You just get a big jet and you don't understand where the hole is. So we rely on echo more. So we decided to leave a safety wire here, and through the sheath we thought we will put a large an AVP3 device and see what happens, and if it occludes, fine, well and good, and then after the device perhaps we can reassess with echo. That is our plan.
So the next.
So the AVP3 device we chose was a 12 by 3. Can you show the box on the camera, please? I think it's important to show the box because that box actually shows the device profile, how it is, because it's hard to get an AVP3 in the market.
Gopal, you have about 4 minutes.
You can see here it's a rectangular device. Sir.
Gopal, you have about 4 to 5 minutes in the first time. Then we'll go to MMM. We'll come back for you for 10 minutes. So you can plan how you would like to show to us.
Okay. Any suggestions? We'll just show you the AVP3 deployment.
And we can show that other case.
Next. So here you can see here, we just lined up that AVP3. We left the other wire as a safety wire, mainly to upsize or take another sheath if it doesn't close off completely.
Next. They say 45 minutes.
Next. And here you can see the AVP3 is deployed, and it did not affect the valve significantly. Next one. This one demonstrates the valve function to be normal with the AVP3 side by side. The important thing we noticed was the AVP3 managed to get its full shape, and that is not a good sign. Usually we would expect it to be a bit constrained if we get a very tight fit, but clearly we don't have a tight fit. So we left the cable there. We did not release it as one would do, and we went to the echo. Just show us the echo now, please. So the blood pressure from 27 has come up to 35.
30 minutes from now.
Please get the echo screen. So on the echo screen, you can see here the LV aspect of the disc is clearly visualized. There is another jet very close to it, again in the iotomitral confluence. It is not on the other side, and it's fairly broad jet. And it doesn't seem to be on the annulus. It's more coming towards the center of the valve. What are the panel thoughts? Dr. Sivakumar, what do you think?
This also looks like a paravalve. As I told earlier, I'm anticipating some sort of a leak between 12 and 1 o'clock. So if you probe on a lateral view with your catheter directed completely posteriorly, whether you can get some sort of a straight thermo down, leaving behind this 12:3 AVP3 in the same location. Did you try passing a wire now through the posterior location?
So we are, the device is completely posterior. You can see here my wire straight away passed through. I'm just going to take the wire again and demonstrate what I'm doing. Come as LAO as possible. RAO lavanga. Okay, I think that's outside. Show me if I'm inside or outside, please. Just show me the heart navigator. Come back, move around. So we are also using heart navigator because if we were to use an AVP2, we may have the disc going up to the coronary, and the heart navigator will help us live without coronary shots to give us an idea whether we are close to the coronary or not. So that helps also.
This is through the valve.
So I'm posterior. I'm away from.
It looks like through
come
the
back.
valve. That looks
show back.
Come to the other view.
Show if I'm outside or inside.
This is through the central orifice of the valve.
Yes, you're right.
Agreed. Again, center. Come RAO. That's it. Keep it there. Okay. There you can see clearly it's very close to the previous device.
Yeah. If you do a lateral here, we can see whether the wire is posterior to this parallel.
Come lateral, please. True lateral.
So TE probe minus.
TE probe eduthukumma. Come lateral.
Yeah, this is coming anterior.
So this posterior.
This is anterior. Your wire is anterior now.
So we're going to change direction.
Yeah.
So I'm just poking posteriorly, as you suggested. We actually went through this area previously on the on-fast view, but let us try again because we didn't see any hole in this region. Show me the heart navigator. Okay, great. Again, you can see here it has gone in a completely different area. Did you see that? Say
Yeah,
that?
it's quite anterior, yeah.
It is well away, it's well away from the previous device, which is very anterior. Can you see if the wire is through that hole where you have column on TOE? Come to a different view, please. Because we are not taking the wire through the device or going through any residual hole through the same confluence. It's clearly independent of the previous device, suggesting either a bigger hole or a small hole next to that. So I think we will probably upsize and take a ADO. What do you think? What are your thoughts, Dr. Sivakumar?
I think through this wire you advance a guide catheter and put in another vascular plug here, maybe an 8 millimeter circular AVP2. Keep knocking out more and more orifices and see whether the leak is becoming better.
I was a bit worried about using AVP2, sir. What do you think? Because AVP2, I'm just worried about the two lobules because if it bends towards the LVOT, towards the valve, we're going to have interference. What do you think? I was hoping we can use an ADO, maybe a 10/8 ADO and pull it all the way back because we will have a 12 or 14 millimeter on the LV disc anyway.
Yeah, the AVP2, if you are slightly oversizing by using say an 8 or a 10, and if you keep the central belly on the paravalvular leak, the two discs will go a little away from the valves. So that is also another safer option. You just advance the catheter and have a sense about how big it is. If the catheter is easily walking in or just advance any of the catheters and see whether it is
Just
easily walking in.
6 French, yeah, the catheters I think should go.
Excuse us.
There you go. You can see the 5 French going very easily. So it can't be too tiny hole either.
Yeah.
Yeah, excuse us.
Stiff wire, please,
We
and
have to
take
go to
7
Madras.
French.
We have to go to the other
Okay.
hospital for the. We will come
Fine,
back to
we
you
will-
and find out what you
We
have
will
done.
get on. We're going to upsize to a 7 French. We will see what we can do. We'll keep you.
What are you
posted.
planning? Which device are you
Thank you.
planning?
So the plan is to upsize to a 7 French sheath and take an ADO, ADO 10/8, and see what happens.
Okay. We will come back to you. Thank you.
Okay.
Thank you.
Thank you. So when you were with us, we did AVP3, and after AVP3, we found a more leak, and then we crossed it with a 7 French sheath, and we put an AVP2. The size we chose was a 12 millimeter
Back.
AVP2 with the hope that we will be able to close up any hole. So here on the fluoro, you can see here the AVP2 release. Back. Play. So here you can see here a 7 French braided sheath, and then AVP2. And then here I thought it's a bit more LV, so I pulled it back. Next. So here I just pulled it all the way so that I had a snug fit, so that there's absolutely no interference with the top end, and then pushed the top end as much as possible to try and sandwich any tiny holes around that area with this big mesh of nitinol. That was the idea. You can see here me trying to push forward. Next. So now we're just making sure this is not affecting the leads. Show us heart navigator. And the heart navigator, we were sure that it was well away from the coronaries also. And then we released it. You can see here now it's completely released, and these two are not affecting the valve leaflets. So let's go to echo. Echo on the previous view, the short axis. So on the short axis on echo, where we had a large leak on the 9 o'clock area, is completely gone. Now we have another hole which is somewhere on the anterior side, surprisingly. We'll show you the anterior leak now. Go back one. There was another jet. This is not the anterior one. There. No, sorry, I beg your pardon. This is not the anterior. There is another hole there, which again, what we saw like a crescentric on the short axis is gone. Our diastolic has gone up to 40 now from 23, but we are still left with another small hole. So the plan is now to try and get this, and which is why we released the device here, because we didn't think we were going to add much by leaving these devices connected and taking another puncture on the patient's femoral artery. So now the plan is to try and cannulate this and then hopefully close it. That is the plan. Any comments from the panel?
Shiva?
Yeah, I think Gopal, I think target this same lesion, which is looking like it is on the iotomitral curtain, quite posterior. I think it is between that same 12 to 1 o'clock. Your previous straight thermo wires were not crossing at all. It is sometimes if the leak is at a sharp angle, the straight thermo will go and hit the mitral annulus and it will not go. So now you try with a J thermo and just move the thermo wire in that posterior annular location and see whether you will get into the left ventricle.
So we're going to use exactly a curved Turumo and a multi-purpose rather than AL1, so that because AL1 is going to poke right away, we want something going towards the actual annulus. So we're going to choose a multi-purpose and a curved. 7 French. I don't know how much time you have. If there's no time, well, I guess we will keep you posted where we got to later on.
Now you have time as of now, because looks like Dr. Gopal, can you hear us? Dr. Ajit's team finished off very early.
Okay.
They have given you 10 minutes credit from their side. So you have another 10 to 12 minutes to go.
Very kind of them.
Show the other case.
Okay.
If that is the case, we will show you the other case, which is the more interesting as well, which is almost a zero contrast TAVI.
Yeah, perhaps you can do that while I exchange this.
Show that presentation.
Give us
please.
7 French more.
Show that presentation. Show the previous presentation. So basically that patient had a creatinine of 5 and a severe aortic stenosis, severe LV dysfunction. We'll show you the presentation in a second. And we did with about 15-20 ml contrast, the total TAVI procedure.
12, by the way.
12 ml contrast. I'll show you in a second. All guided by TE, 3D TE.
No, we thought this was another case interesting to show. We didn't think we will have time. Now that we have time, we thought we will share this because this is a completely ultrasound assisted, ultrasound guided TAVR procedure without any CT femoral, no gated cardiac CT and no contrast. Because we have a huge number of patients, everybody has in their practice of renal failure, they can't have CT. This is not to say that this is the way forward, certainly not the case, but at least to show feasibility and safety in selected cohorts. That is the message. So over to you, Dr. Raman.
Yes. Show the next slide, please. So this is the background. Previous CABG 2002 graphs, diabetes, renal impairment. Creatinine is 5.3, and he's been having recurrent admissions with heart failure with a neighboring hospital and severe LV. Show the next slide. You can see that. Next slide. That's a 3D. It was totally ultrasound guided.
Curved Rumo.
Next one.
Curved Rumo.
Next, please. So it showed severely calcified, severe aortic stenosis. Next slide, please.
Type 0.
And it was a bicuspid. Now this view you can see it's a type 0 bicuspid. Next slide, please. Calcified bicuspid. Next. because the sizing, so TAVI sizing for bicuspid is slightly different compared to the tricuspid. Tricuspid, you are dependent on the annulus. If you are using a self-expanding perimeter, a balloon expanding area. Now for the bicuspid, we take it around 5 millimeter above the annulus and 8 millimeters. And because the sort of sealing of this transcatheter valve will be not at the annular level, it will be higher up with the bicuspid. So that 5 millimeter from the annulus will give you the best in terms of sizing. Next slide, please. Next slide, please. So that shows the true bicuspid. Next slide, please. So it was totally ultrasound guided. Now we are having this femoral ultrasound. Next, please. And this one is we are sort of panning up from the femoral right up to the sort of iliac bifurcation, bending over the femoral head. Next slide, please. So we are satisfied with the size of the vessel. It was around 6 millimeters, and what we need is a 5.5 for a repositionable evolute or valve. These particular cases where you are going to go for almost zero contrast, it's better to use a self-expanding evolutor because you have the option of recapturing and repositioning if you are not satisfied. So next slide, please. Next slide, next please. Next slide, please. So once we got the ultrasound guided puncture, next slide, please. We always use this contralateral technique. That means from the left femoral, 4 French or 5 French, then we are going to the right contralateral. Next slide, please. Here we are not using any contrast. We are aiming towards the head of that pigtail, and we use 2 proglides as a pre-close. So far no contrast is used. Next slide, please. This is the only contrast we used because we needed to know whether the lima is functioning or not, especially given the severe LV. If it is a lima dependent circulation, it's very important that we don't taste this patient during the implantation. So this view shows that we got 2 pigtails in the 2 cusps. So we are going to use this as the landmarks for deploying the valve rather than taking any iotogram. So next slide, please.
The annulus measurement and all is by echo.
Normally we do an iotogram.
The measurements are
the
all
annular
done.
measurement was completely based on multiplane reconstruction of echo. So we use a live 4D echo where we have an X-plane and we can have exactly the same values if whatever one can get from CT. We've also done it for balloon expandable and self-expanding. And self-expanding would be the safest because you have the ability to retrieve as many number of times as possible if you get it wrong, and the risk of annular rupture is probably near zero.
Did you
back
use
to the presentation,
Back
please.
to the presentation, please.
Did you use TE in this case?
Yes, it's
Yes,
fully
yes.
TOE.
It is
guided.
fully TE guided, 3D TE guided. So we have crossed it with the AL1, you saw that wire, and so far no contrast apart from the lima shot, which is about 4 ml. Next slide, please. So here we are using an evolute or 23 millimeters repositionable valve. The first deployment we were a little bit not satisfied because on one side it looked like about 0, but the other side it was almost 7 to 8 deep. So we recaptured. That is the beauty of this valve. You can completely recapture and reposition 3 or 4 times. Now we have deployed 2/3. Up to that point you can deploy and then you can assess your whole thing. If you are not satisfied, you can recapture and reposition. So the TE here shows that it was deep. You can see it, it's almost 5-6 millimeters deeper. Next slide, please.
These 2 pigtail loops serve as the marker.
Slide, please.
That is,
Yes, absolutely. That's what we are using it to, because
That-
this is bicuspid, so both cusps we have put the
Lateral.
pigtails.
but that has to be coplanar. How will you adjust
And
the?
once we are satisfied.
Usually we take
Yes,
the
yes, absolutely,
coplanar.
you are right. Yes. For the bicuspid, obviously, we have the 2 pigtails and go through your LAO or views, get a good coplanar implantation. Sometimes you see a rudimentary 3rd cusp as well. Here we saw calcification in the rudimentary, so which we used it as a landmark as well.
No, the question what you're asking is how do we know where we are?
Yeah.
This
That
is
is-
from the TOE. So you can see here this is a GA based procedure, fully guided on TOE, multiplane, and we are watching that the pigtail is exactly at the cusp there where we want it to be. and we do an RAO and LAO. Because it's in the interest of time, we're not showing the entire procedure. So let's move.
Yeah, next slide please. So
Okay.
here once we were satisfied, that's the TE showing that it's absolutely perfect positioning of the valve. You can see that new valve, the evolutor is functioning well. There is no paravalvular leak at all, zero paravalvular leak. Next slide please. And the 3D is fantastic, showing again a good valve position. Next slide please. Next.
Lateral.
Next. Again, there is no MR. Next. So the long axis view showing again the good sort of shape of that evolutor valve with no paravalvular leak. Next slide, please. And the gradients was less than 5. Next slide, please. This is a beautiful image of that core valve evolute. You can see it perfectly positioned. It's not deep. Again, it's not higher up. Both sides, it's very nicely sewn, and no interference with the mitral. So this can be done as Gopi was telling earlier. Next slide, please. Next slide, please.
Next
Yeah,
slide.
it's a very good placement with no paravalvular or no significant.
And this is just the final safety, because we always do a crossover. This is when we can run into trouble if we don't have a crossover when we take the sheath out. Next.
Next, please.
And the patient's creatinine was 4.1 at 72 hours with normal urine output mobilizing, and was discharged on day 5, which was actually yesterday. Next. So that's him. He got home. Next. And that was our country's first TAVR, fully ultrasound guided, and it just is a great concept to show safety. We thought we should share
And the
in this crowd.
The company people told that that was the first evolutor throughout the world, which is completely ultrasound guided. Throughout the world, the first evolutor ultrasound guided.
Oh.
So you can do it even without CT as long as you have a good TE, 3D TE.
Very good demonstration,
Am I through
and
the
I think
valve?
this is the way forward, because we are going to have TAVR in the usual risk also. Previously it was in the high risk, now it has gone to intermediate
Absolutely,
risk.
in
Now
our-
the data has come for the normal risk also. So I think this will be the way forward.
And I'm sure in all our practices we have so many patients with renal impairment. So I think meticulous ultrasound use. I think there's a lot of ultrasound experts, cardiac ultrasound, echo experts in the panel. They can give their views, because the accuracy of cardiac ultrasound, i.e. echo with good multiplane imaging, is as good as CT. Although peripheral access is inferior, CT is the best way forward without doubt. But certainly for sizing, one can achieve that with ultrasound, and we have done that even with balloon expandable, where the room for error is very, very short.
And the new sort of echo navigator system is also available in this lab, which makes our life much easier when we deploy the valve.
I think having these systems, basically toys, I would say, a heart navigator, echo navigator, can be of a lot of help in minimizing contrast and fluoro, and adding confidence to the operator, because you have continuous 3-dimensional alignment. Because here, as I'm operating, I have full heart navigator on the other screen, and I'm continuously watching where I'm going in a 3-dimensional plane.
Show that heart navigator, please.
Come lateral, please. Come all the way lateral. So what we are doing now is we are done with those 2 plugs. We are going to try and cannulate the other plug. If you run out of time, that is fine, but we just wanted to share whatever we could.
So I think there are a couple of
But
more
we are
minutes.
gonna
We can
keep
stay
fishing.
with you. You can just try. If you need to go off, we'll let you know.
Okay,
But
sir.
you can try. We'd like to be with you for
Okay,
some more
sir.
time.
Okay, any comments from the panel? Dr.
Any-
Shivakumar?
Any suggestions from Shiva, Dr. Shiva?
CT was
for
not
this
done
particular case crossing?
Okay, check.
Dr. Gopal, was a previous CT scan done for this gentleman, this paravalvular leak?
Yes, correct.
And-
It
and-
was with the CT we have heart navigation.
No, in that, what was this your interpretation about the number of leaks, the position of the leaks on the CT?
Absolutely couldn't make out anything. This is with proper gated sequence. with a heart rate of 65.
Want to
But
see
the
whether
problem,
it's
sir,
inside
as
or
you know, with the amount of metal artifact we have, it is very difficult to know exactly on CT plane where we have. But we thought we have something around where we saw an echo, but I couldn't be confident that this was the hole on CT, because on CT I saw only one hole, which was very, very clear in the aortomitral angle where there's clear continuity from the aorta into the LV. I didn't see any of the holes, but I don't think I can be confident either because of the metal artifact that comes with CT.
Okay. If that is the case, then it is quite likely, because I am seeing you are at least trying in the posterior area for the last 5-10 minutes. It's likely that possibly this is a valvular leak, whatever is remaining, and it is not paravalvular, because you are, I am seeing you probing the entire posterior annular area, and the guide wire refuses to enter inside.
Correct.
Yes.
So this is possible that this is a valve.
Correct.
Like the discs are not possibly completely opposing against each other or against the rim, and this is likely to be a valvular.
Is there any other way to confirm that, sir? Because we actually have done a lot of the conventional stuff that we do, like fluoro, we have multiplane reconstruction on TOE. We continue to believe it's paravalvular. Please put some light on us. How can we be sure? Because we'll show you the echo, and on fluoro you saw the leaflets are absolutely doing a good job.
Yeah, but sometimes
Echo,
the point of opposition of the two leaflets against each other are the semicircular outer rim against the metallic discs. Sometimes if they have worn out, then you can still have a valvular leak. In fact, if you are not identified a second leak on the gated CT, I would assume that possibly there is no paravalvular leak, and all the leaks that is remaining is all valvular.
Valvular from which side, Shiva? Can you just throw some?
Valvular, there are 3 points of opposition. One is the two semicircular discs oppose against each other as a straight line, that is the midline. And then there are 2 lines of opposition of the outer margins of the semicircular disc against the metallic rim. So if there is any area that is worn out, let's assume a small chipping out of the pyrolytic carbon out, or there is just it is getting worn out, so then there can be a valvular leak. And while mitral is extremely good in visualizing with an echocardiography, aortic is extremely challenging. Sometimes aortic doesn't show up nicely on transesophageal or transthoracic. It's a crowded small area there. It's just a 21 millimeter or 23 millimeter diameter, and in that trying to look for a paravalvular leak is quite challenging. If the CT has not shown another leak, then I would assume that this is valvular and possibly stop here.
Will you try antigrade, retrograde?
Okay.
Antigrade if you are not crossing retrograde.
I have never done that for a aortic paravalvular leak, like poking the apex and going in. No, not done that. And to go from the transeptal mitral valve and entering is absolutely, it is not at all possible. Apical is too much for a aortic valve. I think retrograde should be possible.
This surgery was done, about a year back. Do you think a degeneration of the valve can happen in a year's time?
Some valves are bad. Some valves have got, there can be some sort of a manufacturing abnormality or a rapid degeneration. It's possible. We have seen some valves degenerating very fast.
So this in echo will almost look circumferential.
So
look
what
at paravalvular
we are,
like.
In fact, the echo is showing that it is paravalvular, because even now, right now, if it is a live image, it looks like it is posterior.
it is a live image.
Yeah. So
it is posterior.
it's posterior, and this looks like paravalvular. But I saw you almost palpating the entire posterior mitral annulus with the tip of your wire.
Correct, sir. But again, we are, the plan is now, the blood pressure has come up to 41, 42. In fact, this is the biggest blood pressure we've ever had, starting an opening blood pressure of, the blood pressure I mean diastolic, sir. Diastolic we started at 23 was the diastolic. So that's why we started the procedure as soon as we went on GA. Now we have a diastolic of 40, 42. So therefore, we are going to try for some more time, and then otherwise we will declare as a valvular, which we are unable to appreciate, and then we'll see how the patient gets on.
Yeah.
And then perhaps we will do a spectral CT.
Gopal, one suggestion will be you can try from a radial axis, right radial axis. That will give a slightly a different angulation, because when you are going through the entire aortic arch, the catheter tends to move along the outer curvature and tries to go more and more anterior. But with the radial catheter and trying to enter into the aorta, sometimes a different angle might help sometimes.
So thank you, Gopal. In fact,
So
you have
this
shown a very... You go ahead, Gopal.
The radials were all gone, sir. Sorry to interrupt. The radials, in fact, we couldn't even get a radial arterial line for monitoring for anesthesia purposes. We didn't want to go brachial, so we have in fact chosen just the left femoral for arterial line for the anesthetist. So radial, I think it's all been used up, or perhaps at the time of infection, everything got thrombosed. I don't know, maybe arterial lines. But that's a very good point, sir.
So thank you, Gopal. It was a great cases. In fact, you have shown the first in, I think, Asia, probably the world, where you have done a TAVR without a contrast, particularly with this valve. Thank you very much. And this paravalvular leak case again, you're close to, and still we are having a defect which we are not sure from where it is. Thank you very much, and we'll get back to you. Thank you, Shiva, for the thoughts that you have shared. Thank you.
Thank you.
Thank you, sir.
Thanks for having us.